Welcome to this Step 3 review on cancer screening and diagnosis. This video is brought to you by Roadmap to Residency. Cancer screening is one of the highest yield topics on this exam, and it shows up over and over in the outpatient clinic setting the test loves. Here is the thing that makes it so testable. The medicine is not hard. The traps are. The test writers know exactly where you will jump ahead, and they build the answer choices to catch you there. So our goal today is not to reteach every guideline. It is to show you the 4 question stems you will actually see and how to attack each one. Keep your question bank open alongside this video, because these patterns only stick when you drill them. Let us get started. Here is what we are going to cover today. First, we will learn to recognize the 4 screening stem types that the test writers reuse constantly, because once you can name the stem type, the answer choices sort themselves out. Second, we will handle the abnormal result, deciding whether you repeat, confirm, or move straight to the diagnostic test. Third, we will work through coordinating a diagnostic workup without scattering tests everywhere. And fourth, we will figure out when the answer is a specialist referral and when the work is still yours. Along the way, we will walk through 3 practice questions together and explain exactly why every single answer choice is right or wrong. Now, for the guideline numbers themselves, the ages and the intervals, go to the preventive medicine and health maintenance sections of your question bank and the screening tables in your review book. This video teaches you how to attack the stems. Let us start with stem type 1, the well patient screening stem. First, recognize the setup. A patient comes in feeling well for a routine visit with normal vital signs and an unremarkable examination. Nothing is wrong with them. That is the tell. When the stem hands you a healthy patient and no complaint, the question is almost never about diagnosis. It is asking which screening test is due right now. Second, and this is where people lose the point, 2 details decide the answer: the exact age and the risk history buried in the middle of the stem. A smoking history, a first-degree relative with cancer, or a prior abnormal result moves that patient off the standard schedule entirely. So circle the age, circle the risk factor. If neither one is elevated, the plain average risk guideline wins, and the fancier answer choice is the trap. Stem type 2 is the abnormal result stem, and I want you to hear this next line clearly, because it is the single most tested idea in this entire topic. A positive screening test does not give you a diagnosis. It only tells you that this patient has earned the diagnostic test. That is all a screen does. So when the stem hands you an abnormal screen, the correct answer is the confirmatory study, not treatment, not staging, not a specialist. Second, do not skip the confirmatory step, because the trap answer jumps ahead. It will offer you surgery or chemotherapy or an oncology referral for a patient who does not yet have tissue proving that cancer exists at all. So here is your rule. If no biopsy or definitive study has been done anywhere in that stem, any answer that treats the patient is wrong. Get the diagnosis first. Stem type 3 is the diagnostic workup stem. First, tissue is the endpoint. For a suspicious mass or lesion, the workup runs from imaging to tissue. The choices will tempt you with more imaging when what the patient needs is a biopsy. Once imaging has already shown you the lesion, another scan adds nothing. Take the tissue. Second, coordinate. Do not scatter. Each test should answer a question the last one raised. When 2 choices are both reasonable tests, pick the one that changes what you do next. The other is filler. Third, the symptomatic patient is not screening. If the patient has a symptom, a lump, or bleeding, this is no longer a screening question, and the screening test is wrong. Symptoms get a diagnostic workup regardless of what the schedule says. The test writers plant the routine screening option right there to catch you. Let us work through our first practice question. A 52-year-old man comes to the clinic for a routine visit. He feels well and has no complaints. He has never had a colonoscopy. He has no family history of cancer and no bowel symptoms. His vital signs are normal, and his abdominal and rectal examinations are unremarkable. The question asks for the most appropriate next step in management. Before you choose, run the setup check we just learned. Is this patient well? Does he have symptoms? What is his risk category, and what is his age? Read all 4 options carefully and commit to your answer. Then we will walk through the reasoning together. Let us break this down. Step 1. Spot the pattern. A well patient, no symptoms, normal examination, average risk, and one loud detail. He has never been screened and he is past the starting age. That is the well-patient screening stem every time. Step 2, apply the rule. Average risk with no family history means the standard schedule applies, and he is over the starting age with no prior screening. So recommend colorectal cancer screening. Step 3, eliminate the wrong answers. The abdominal scan is the overkill trap, because imaging is not a screening tool for this cancer in a well patient. The surgical referral sends away a patient with no diagnosis and nothing to operate on, and waiting until age 60 leaves him unscreened for years past the recommended start. The correct answer is to recommend colorectal cancer screening. Here is our second practice question, and this one goes straight at the abnormal results stem. A 58-year-old woman had a screening mammogram that shows a new cluster of irregular calcifications in the left breast. She feels well. Her breast examination is normal, and she has no palpable mass. She has no family history of breast cancer. She asks you what happens now. The question asks for the most appropriate next step in management. As you read the choices, hold on to the rule we just covered. Ask yourself whether anyone in this stem has actually proven that this patient has cancer. Pick your answer, and we will reason through every option. Let us work through this. First, screening is not diagnosis. An abnormal screening image is a positive screen. Nowhere in this stem does anyone confirm cancer. Until tissue proves it, this patient does not have cancer. She has a suspicious finding that must be worked up, and those are two very different things. So why does biopsy win? Because biopsy is the confirmatory step that converts a suspicious screen into an actual diagnosis. Now look at what the other choices do. The oncology referral and the staging scan both leap ahead of a diagnosis that does not exist yet, and staging something unproven is meaningless. And repeating the mammogram in a year ignores a suspicious finding and delays a cancer that is treatable right now. The correct answer is to obtain a biopsy of the abnormal area. Stem type 4 is the referral question, and this one has a clean rule. Referral is earned, not given. Ask yourself one thing: has anyone proven this patient has cancer? If the answer is no, then the referral choice is wrong, no matter how reasonable it sounds sitting there on the screen. Referral becomes correct once you hold a tissue diagnosis and the decisions ahead genuinely belong to a specialist. Before that point, the workup is yours. Second, deliver the news, then coordinate. When a biopsy confirms cancer, the test writers very often ask what you do next, and the answer is rarely to hand the patient off silently. Disclosing the result to the patient and arranging the specialist visit is the answer that respects both the diagnosis and the person in front of you. Watch closely for choices that withhold information from the patient or leave the disclosure to someone else. Those are always wrong. Here is our third practice question. A 62-year-old man had a colonoscopy for screening that showed a mass in the sigmoid colon. Biopsy of the mass confirms adenocarcinoma. He feels well and his vital signs are normal. And notice this last detail because it is doing real work. He does not yet know the biopsy result. The question asks for the most appropriate next step in management. Run the filter. Does tissue confirm a diagnosis here? And if it does, what does that unlock? Read all 4 choices very carefully on this one because 2 of them look similar and only 1 is right. Choose your answer and we will reason through it. Let us break this down. This stem is the mirror image of the last one, and that is the whole point of putting them together. Tissue has confirmed adenocarcinoma, so the diagnosis exists, and the decisions ahead genuinely belong to a specialist. This is exactly the moment when referral becomes the right answer. So disclose the diagnosis to the patient and refer to oncology. Now the key distinctions. Repeating the colonoscopy simply reconfirms what the biopsy already proved and delays care. Starting chemotherapy in the clinic is far outside your role and skips staging entirely. And here is the subtle one, the choice that catches good test takers. Referring to oncology while letting the specialist inform him withholds the diagnosis from the patient. It sounds efficient, it is never the answer. The correct answer is to disclose the diagnosis to the patient and refer to oncology. Here is the pearl that ties this whole video together, and if you remember nothing else, remember this. It is the 3-question filter. Before you even look at the answer choices, ask 3 things. Does this patient have symptoms, or is this a well visit? Has any test come back abnormal? And has tissue confirmed a diagnosis? 3 quick questions, all answered from the stem alone. Then let the answer fall out. Well, patient with nothing abnormal means screening. Abnormal result with no tissue means the confirmatory test. Tissue confirmed means referral and disclosure. And symptoms present means diagnostic workup, never screening. Place your patient on that ladder before you read a single choice, and the wrong answers announce themselves because they are either doing too much or too little for the rung that patient is standing on. That wraps up our review of cancer screening and diagnosis for Step 3. Remember the core ideas. Recognize the well-patient stem and let age and risk decide it. Never let a positive screen become a diagnosis in your head, because a screen only earns the confirmatory test. Move from imaging to tissue when working up a lesion. And save referral for the patient who actually has a diagnosis, and tell that patient yourself. When in doubt, run the 3-question filter. For the guideline numbers, go to the preventive medicine and health maintenance sections of your question bank and the screening tables in your review book. Read every explanation, even on the ones you got right, because the reasoning is the point. Visit roadmap-to-residency.com for expert tutors and residency advisors who can help you build a personalized study plan. If this video helped, please like and subscribe so you do not miss our next board review session. Good luck on your exam.